And a good evening and welcome to MedStar Health Structural Heart Disease Webcast. We are streaming to you live tonight from MedStar Union Memorial Hospital here in Baltimore and on the MedStar Health Facebook page and our YouTube channel. I'm your host, Jamie Costello from WMAR-TV, and in just a moment, I'll be joined by a team of experts to talk about structural heart disease, what it is, and the amazing advancements in treating them that are available right now to you. So if you have questions, now's your chance to get answers in real time. You can post them in the comments section on the MedStar Health Facebook page or the MedStar Health YouTube channel. We'll put those questions to our specialists right here, so stay tuned. We have a lot to get to here tonight. Don't forget to share the live stream to your own page so your family and friends can watch and learn and listen as well. We have the A-team with us tonight, and as always, we begin with the W's. Dr. John Wong is the nationally recognized leader in interventional cardiology and the chief of cardiac catheterization labs here at MedStar Union Memorial Hospital. He is right down the hallway. Hey, can we have the photographer just pan to show that there's work to be done in that room? There you go. Look. Dr. Najjar is the regional chief of cardiology for MedStar Health in Baltimore and a known expert in advanced heart failure, and he'll be streaming to us from the Open Heart Clinic. And we have Dr. Bethea, chief of cardiac surgery at MedStar Union Memorial Hospital and the regional chief of outreach right here in Baltimore. And Dr. Rachel Marcus is also joining us, is the cardiologist and the medical director of the Echo Labs at MedStar Good Samaritan and Union Memorial Hospital, and she's going to be talking to us about imaging the heart. So let's get started. And what structural heart disease is. We know it involves abnormalities in the muscle, the valves of the heart chambers, but are people born with it? Doctor?
Thank you, Jamie. I can go ahead and get started. Let me start first by thanking those who are actually joining us live and also those who are going to listen to the podcast at a later time. And also thank you for having this session on structural heart, because structural heart is something that is, as a name, is not as well known as some other things like heart attacks or stroke, but this is actually a growing field in cardiology and cardiac surgery, and it's something people are going to keep hearing more about. And to be able to explain it, let me take a minute, if I may, just to give a little background information. This may be a review to a lot of people in terms of how the heart functions. So the way blood flows in the heart is blood comes from the body to the right side of the heart. There's the right upper chamber, right lower chamber. Then the right lower chamber pumps the blood to the lungs, and that's important because that's where the blood will get oxygenated. It goes back to the left side of the heart. There's an upper chamber and a lower chamber, and the lower chamber on the left side of the heart is the main pumping chamber of the heart, and that is a muscle, very strong muscle that has to squeeze, and it squeezes blood, and that's how the blood goes to all the organs. Every organ in our body, the brain, the kidneys, the liver, the heart, the muscles, all of them obviously need blood because that's how they get their oxygen and how they get their nutrients. Now, in addition to being a muscle, in order to allow blood to only go in one direction, there are actually valves that are built inside the heart. So on the left side of the heart, for example, there's a valve called the mitral valve where the blood that controls the blood coming into that main chamber. And then there's a valve on the other side of it when the heart pumps that has to open up to let the blood flow in one direction over to the rest of the body. And so structural heart basically means that there's a problem with one of these structures. Could be in the muscle, or it could be in one of these valves or one of the other valves. And for the purpose of this discussion today, we're going to focus mostly on an issue that can happen with the valves. So the valves are not working well. If they're blocked or they're leaking, that leads to structural heart. That's the basis of what we're going to be talking about today.
All right, Dr. Wong, who are the patients that come here and who gets structural heart disease?
Jamie, it's a great question. You know, structural heart disease is so common, like Dr. Najjar talked about. Really, it's a catch-all phrase for any problems within the structure of the heart, hence the term. So we talk about heart valve disease, which affects about 2.5% of patients in the country. And structural heart disease itself, though, this catchphrase, it includes the heart valves, the heart muscle, and even problems with some of the structures within, like the wall separating the right and left side of the heart, You can be born with congenital abnormalities and communications or holes that shouldn't be there. So this entire field of structural heart affects about 10% of people over the age of 75, so quite common. As was alluded to earlier, you can be born with some of these structural heart problems from congenital defects. You can acquire some of these, and a lot of these, particularly ones with the heart valves, whether it's the aortic valve or the mitral valve, occurs just because the heart valves wear out over time. And it's the wear and tear of these heart valves. And that's why this is so common. Again, 1 in 10 people over the age of 75 will develop some kind of structural heart disease.
What does the structural heart disease do to the body, doctor?
Well, let's talk a little bit in details of what can happen with the structural heart. So if there's a problem with one of these valves, as Dr. Wang just mentioned, what happens is, let's say that the valve is leaking. So when the muscle of the heart squeezes, instead of all the blood going forward, some of the blood is going to go backward. Or if the valve is tight and it's hard to push blood through it, all these can lead to the blood going backward instead of going forward. And as a result, the other organs are not getting the nutrients that they need. They're not getting the blood flow and the oxygen that they can need. And eventually, that can lead to injury to some of those organs.
All right, tell us what the symptoms are. Everybody's on Facebook right now. They're watching us live on the YouTube. What are the symptoms?
Initially, when things are very mild, there may not be some symptoms. But as the structural heart progresses, people start developing progressive symptoms. And the common ones are the blood is backing up from the heart. It will back up to the lungs, and then it'll back up to the rest of the body. So some of the things that people will complain about is they're getting more shorter breath. Initially, it's getting shorter breath when they're trying to do activities. And then as this progresses, it may get to the point where people are shorter breath even when sitting down. And then as blood backs up to the rest of the body, it starts seeping. And as you can see on the screen now, we look at people's legs and you check and see there's fluid that's there, that seeped out of there. That's fluid that should have been pumped forward from the heart. But because of the structural heart, it leaked backward and made it throughout the body. And therefore, now we have extra fluid that shouldn't be there. So
hey,
that added fluid.
Doctor, I'm sorry. Are they on one side of the leg by the ankle, or is it on both ankles?
It's actually on both sides of the legs. You can see it on the screen. There's only we're sort of showing one side, but actually usually you see it equally on both sides of the legs.
Okay.
And so when people start seeing swelling in their legs, or when people start feeling short of breath, or if they're getting more and more tired, those are the kinds of things that we want people, when they have those symptoms, to go ahead and call their healthcare provider and let them know about these symptoms, because that's often the earliest sign that there's something there that will need to be looked into more carefully.
Okay, Dr. Najjar. Now, heart valve disease is the most common type of structural heart diseases. According to the CDC, that over 2 million people in this country have a leaky heart. And for years, these structural heart conditions were treated with open heart surgery, but now less invasive approaches are advancing treatment options for people with medium to high risk for surgery, and they're done in the state-of-the-art cath lab like the one you're in right now. Dr. Wong, just show us around the room here. What are we looking at?
Sure. This is one of the 2 cath labs that was just completed the last year, and it's the state-of-the-art Philips system, the Philips Azurion system. It gives us incredible resolution when we're actually doing our procedures with the lowest amount of radiation for both the patients as well as the operators performing this procedure. It used to be that when structural heart procedures were performed, we were in what was called a hybrid OR, where you were able to do open heart surgery as well as catheter-based procedures with X-ray equipment like this. But I would say over 95% of procedures now in the United States are done in state-of-the-art cath labs like this. So my partners, Dr. Bethea, the chief of cardiac surgery, which you'll be hearing from, he and I work side by side, and we replace heart valves in a minimally invasive fashion in rooms such as this with catheter-based procedures. Of course, this room is multifunctional, and we can do standard heart catheterizations as well, where we're looking and seeing if patients have blockages in their blood vessels and fixing them with stents, which people are typically familiar with.
All right, let's bring in Dr. Bethea, hybrid room. Explain what the hybrid room is about, doctor.
As Dr. Wong alluded to, that's where we first started structural heart. It's about a 10-year-old concept, and like he mentioned, we moved most things down to the cath lab, except for the few structural heart cases that still require an open incision. So the hybrid room, was something that was all the rage about 10 years ago, and over the last, I would say, 3 to 4 years, most people have started to transition into the cath lab.
And what are the conditions that you treat the most? What are some of the most common that you're treating the most in there?
Well, interestingly, Union is one of the few institutions in the country, we're talking about 5%, that we have, Dr. Wong and I have the capability of treating all the valves in the heart. Now, we don't focus on the pulmonary valve, but the aortic valve, the mitral valve, and the tricuspid valve. And I think one of the key things here is why you have all 4 of these experts here. It is a team approach. And without Dr. Najjar and his team optimizing patients and helping us take care of them in their postoperative recovery phase, we wouldn't have the success that we have, and we wouldn't be recognized as a national leader. Furthermore, with Rachel, Dr. Marcus and her team, if we can't see it, Dr. Wong and I can't do it. So we depend greatly during these procedures for Dr. Marcus and her team to provide us with the same images that I'm used to seeing when I'm performing open heart surgery. And so, it's a very rare institution, and Union Memorial just happens to be one of them that has this collection of experts to perform at the highest levels. Now, a lot of institutions do structural heart, but they don't have all these collective experts on hand. And I think that the patients benefit when you do have this multidisciplinary approach.
Explain to us while we have you right here, doctor, heart regurgitation. To help us understand what that is.
Yeah, so I think the video that you're showing is really dealing with mitral regurgitation. It appears to be what we call a Tendine procedure, which is a transcatheter mitral valve replacement. We also have transcatheter techniques that aren't done with an incision through the right common femoral vein. I think that is the future of this field, and I envision a day when patients will go home the next day after receiving a mitral valve replacement in the mitral position. Furthermore, we can also treat the tricuspid valve, which is something that, because of the late referrals, not a lot of surgeons are excited to do tricuspid valve surgery, but now we have transcatheter options for the tricuspid valve where patients can go home the very next day. And so I think this is the advance. If you think back 100 years ago, we were putting leeches on patients thinking that we were doing them a favor. And ever since I went into cardiac surgery, I had a feeling that in 100 years from now, people would look back on me and think I was pretty barbaric for ever opening a patient's chest. And so this is why this is exciting, and this is why we're excited to offer this to the community of Baltimore and the surrounding areas here at Union Memorial.
Unbelievable. We have a YouTube viewer who wants to know, how do I refer a patient with ASD with partial anomalous venous return? Who wants to field that question? Doctors?
Well, an atrial septal defect is a communication between the two top chambers of the heart. By itself, an ASD can usually be closed with a catheter-based procedure, but if the person actually has an anomalous pulmonary vein, typically that's still corrected with cardiac surgery. So that viewer that submitted the question is talking about a vein that normally would return to the left side of the heart, the left atria, all 4 veins. But some of us, again, when I was talking about these congenital disorders, are born where one of the pulmonary veins, and sometimes more than one, actually return to the right side of the heart. And so that one particular anomaly associated with an atrial septal defect is still corrected with open heart surgery.
All right, we have a Facebook viewer, Millie, wants to know, what does multivessel coronary artery calcification mean? Can you explain this to me, please? To Millie.
Yes, this is a very common question, and it's a very popular test to get a CT calcium score, and it causes a lot of worry. Calcium occurs in the walls of the blood vessels that feed the heart. There is an association between a lot of calcium in the walls of the blood vessels of the heart and cholesterol narrowings, the narrowings that can actually cause patients to get chest pain or angina or angina or even a heart attack. But just by having a lot of calcium does not mean you actually have a blockage in the blood vessel. So if you could choose, do you want to have calcium in your blood vessels? I always tell patients, of course, you would rather not have calcium because there is this association. But by no means does having a lot of calcium in your blood vessels mean that you necessarily have a blockage. For those of you that are familiar with the score, some people will say my score was a 0 or it was 50. I've had patients with scores in the several thousand that don't have significant blockages. Again, the calcium score is more of a picture of the blood vessels, and a test that oftentimes is more useful is a functional test, such as a nuclear stress test, or ultimately the gold standard, which is to take a look in a state-of-the-art cath lab like this through a catheter-based procedure done through the wrist, where in under 5 minutes we can determine if those calcium deposits in the wall are associated with a cholesterol narrowing.
All right, Dr. Marcus, on your toes, but one more with Dr. Wong here. Explain to us, share the TEE is used for imaging. How does that work?
Yeah, I'm going to defer this to the director of the Echo Lab, Dr. Marcus, who will explain.
All right, doctor, I told you to stay on your toes. Doctor, explain this.
So the TEE is a test that uses ultrasound to be able to take pictures of the heart. And here you're seeing that we have somebody who's getting a scope put into their esophagus, which runs in back of the heart. And you can see how close it is. And it's actually really close to the heart valve. So we're able to get really beautiful pictures in ways that sometimes we can't if you put the probe on the surface of the chest. So the reason why TEE is so important for the structural heart procedures that we do is that the surgeons actually can't see the valve while they're doing the procedure, unlike if they were doing an open heart procedure. So what is on the screen right now is an example of a TEE that we were doing prior to something called a mitral clip procedure, which is a structural heart procedure that allows us to fix a leaky mitral valve. What you're seeing on the left-hand side of the screen are two different images of the mitral valve, and the color that you're seeing is the leakage, the mitral regurgitation, we call it, that is actually coming up the valve into the left atrium. And on the right-hand side of the screen, that's a three-dimensional image. Now on the screen right now, you're seeing some of the things that we do to help guide the procedure. We actually have to make some measurements for the surgeon and the interventional cardiologist to make sure that they're accessing the heart in the right way. And here you can see us watching as they put one of their catheters across what we call the interatrial septum, which is going to allow them to deliver the mitral clip. Now, on the right-hand side of the screen, you're again seeing a three-dimensional image of the mitral valve, and this is the mitral clip. We're getting ready now to actually advance this mitral clip across the mitral valve. And the mitral clip is basically going to look like a clothespin. Once it's been deployed or put into place, it's going to cinch the leaflets together. It's really a joy for me every day to work with this remarkable group of people, and I just am so grateful to have a chance to be on the team. I'm happy to be able to play my role in the procedures. I think I am able to show them beautiful pictures of the heart valves so they can see exactly where it is that their devices need to go. But I'm just always so thrilled at the end of a case where a patient is able to leave the procedure room and then leave the hospital in much better shape without actually having to have the kind of surgery that Dr. Bethea might have had to offer them a decade ago.
Okay, let me go back to Dr. Bethea because we have some great animation here. Tendine, explain this to us. Can you talk to us about that?
So this Tendine is an interesting technology that was really the initial kind of pioneering device into transcatheter mitral valve replacement. And Dr. Wong and I, we actually have performed more than anyone else in the country to date. But this here, it shows it's a transapical procedure. So it does require an open incision where we access the apex of the heart and we feed a wire into the left atrium. And then this is the catheter that houses the valve. And we're going to go up and essentially position this within the patient's native aortic valve. And then I think it's important to know that this particular platform can treat all varieties of mitral valve disease. And after a couple of clicks of the button, you actually can deploy the valve. And what's fascinating about this is that Dr. Wong and I can, if we're not happy with the initial position, we can actually, it's extremely precise. And for the viewers, we're essentially performing beating heart mitral valve replacement without truly opening your entire chest. It's through a very small 2 to 3 centimeter incision. And then this is the apical pad that goes onto the apex of the heart to help with both, to seal the hole that we've made, as well as to anchor the valve in position. And you can see we have a nice new normal mitral valve that has pushed the patient's diseased mitral valve simply to the side. The procedure in our hands takes about half an hour. We also work with transfemoral devices, which requires no incisions, and that may take us slightly longer. I would say the procedure time is maybe hour and a half, but the same result is achieved. So that's sort of the next evolution in this field.
All right, we got the mitral down. How about the aortic valve? Tell us about that, the aortic valve, doctor.
So the aortic valve is the valve that's supposed to open and close like this every time the heart beats and to allow blood to get to the rest of the body. As we get older, calcium builds up on this valve and it gets stenotic. And that's the most common problem with the aortic valve is it gets stenosed and restricted with calcium so it doesn't open. Dr. Najjar talked about the symptoms patients get. They can get lightheaded, they can pass out, they can get swelling in their legs or have heart failure, difficulty breathing, or even chest pain. When that happens, prior to actually 2012, when TAVR or transcatheter aortic valve replacement was developed, the only way to fix this was open heart surgery. But now, with a catheter the size of a number 2 pencil in the femoral artery, we can pass up a wire across this tight valve, use a balloon to open that valve and make way for the new valve. And this new valve, you can see, is passed over a catheter. This is the present generation we use now. And in order for it to be as low profile as possible, we actually seat the valve over the balloon markers in the body. And once we have it in position, we pass it through the native aortic valve, the diseased valve. A common question people always ask is, do we take that valve out? And the answer is no. We use the diseased calcified valve as an anchor to hold on to the new valve. And you can see in this animation, we're crossing across the aorta, the big blood vessel that comes out of the heart. And now we are going across the native aortic valve. And once we're across the native aortic valve, we fine-tune the position of this valve, and under rapid pacing at about 180 beats per minute, we inflate the balloon, which inflates this new heart valve. When we deflate the balloon and stop our pacemaker, you can see the new heart valve starts working immediately. This procedure, from the time we make our first little nick in the skin to the time we close the skin, is 30 minutes. And I would say 85% of our patients go home the next day. It's really remarkable. And again, this is technology that is available here, but was only developed a decade ago. This is the one we showed in the initial animation is the balloon expandable valve. And this is a self-expanding valve with nitinol, which is a different type of alloy. Both have particular characteristics. And again, we can choose the proper valve depending on the patient's anatomy. One valve is not always the best for every single patient.
Let me ask you, I want to get back to the esophagus part. If you're having acid reflux or you're unable to sleep at night because of the esophagus, you know, the GERD and all that stuff, does that lead to heart disease, or is that a precursor to heart disease?
Acid reflux is not a precursor to heart disease, but I can tell you having acid reflux and having discomfort in the esophagus is oftentimes confused with heart disease, and that can be excruciating chest pain. So both ways, people can have true heart disease that they think is acid reflux, and people can have acid reflux that they think is heart disease. So it is oftentimes confused, but having acid reflux is not a precursor to developing heart disease.
I want to bring in Dr. Bethea. You were talking about leeches before. What is the biggest advancement that you've seen in your career, one that you thought you would never see? What would that be?
Well, initially, I was in a field very similar to Dr. Najjar, and I think the artificial heart pumps or left ventricular assist devices was one great step. But I think this being able to treat the valves, and I should mention also that what John does in the cath lab with percutaneous interventions is fantastic. And now that we have the valves, I think that is just the next leap forward. Now, I think what if you ask me really what is the biggest difference, I would say the biggest difference is how all of these experts on this call tonight, we get together and actually discuss patients. In days gone by, patients were discussed in silos. And if you came to me as a surgeon, I would only offer you what I could do. And I do not think that that is what's best for the patient. What's best for the patient is offering them the therapy, as Dr. Marcus alluded to, that is best for them. And we individualize it here at Union Memorial. Not all tools fit each patient. And we're very pleased to be able to offer every single tool to help every single patient, whether it be coronary disease, heart failure, or if it's one of their valves. I think that communication, that teamwork is the greatest advance we've seen.
Let's go back to the new cath labs that Dr. Wong is standing in right now. And Doctor, just give us a little quick tour of what we're seeing behind you.
Right. So this is one of the two new cath labs, and MedStar is actually this fall going to be renovating 2 more. So we'll have 4 brand new labs. This really is the state-of-the-art equipment, and we're able to have anesthesia machines and do the structural heart procedures. Again, we have such a nice large monitor here that we can actually position and make the different screens smaller and much like a tile, like an iPad. We have abilities to make measurements in here, do intravascular ultrasound and look at the actual vessels, measure the hemodynamics within the coronary artery. So it really is the state of the art. And again, like I mentioned earlier, it really gives us the best imaging with the absolute lowest amount of radiation. One thing though, Jamie, I have to add to my colleagues, and I'd be remiss not to add this, is that in addition to offering all these exciting therapies to our patients and individualizing them and working as a team, I echo all those sentiments. But the other thing that really differentiates us as a group is that all of us participate in clinical trials. And MedStar Union Memorial is one of the top enrollers for many of these clinical trials with these new therapies that really aren't even available to patients unless they decide to participate in this. So all of the structural heart procedures that have been developed and are available presently today, we at MedStar Union Memorial participated in the clinical trials that allowed them to become approved by the FDA. So we have, again, at least 2 heart valves that we're evaluating in the aortic position for brand new aortic heart valves that are not available to the general public yet, that have not been approved, that we are part of the clinical trial. We have mitral valve technologies and tricuspid valve technologies. And so this is something that I always try and explain to patients, that one of the advantages of choosing this is not only do you have this multidisciplinary team approach, but you really have access to tomorrow's technology today. And that's a big differentiator.
All right, we have a couple minutes left, so let's go rapid fire here, like your ticker here. Facebook viewer Terry wants to know, I dislike the thought of catheters. Is having a catheter-based procedure painful? Who wants to answer? Go.
The short answer is no. It's actually done with light sedation and a little bit of a twilight, and then we numb up. Most procedures are done through the wrist. If you're having a heart valve replaced, it's done through an artery in the leg. And this is a little video of, or a still picture of a procedure on a patient who just had a heart catheterization done through the wrist. It takes about 5 minutes if we're just taking pictures, and that little wristband is on there for about an hour. Patients can sit up, walk around, eat with their left hand, and it's a completely different procedure than when we used to have to do this from the leg. So the short answer for the viewer, no, it's not painful.
You can get heart treatment faster than you can get an oil and filter change. That's crazy. Yeah. And with this catheter valve replacement, does the patient need to be on a blood thinner? That's another question from our Facebook family.
Usually not a blood thinner like patients think about, not a Coumadin medicine or Eliquis medicine, but they do have to be usually on a baby aspirin, 81 milligrams a day, and short-term antiplatelet agents such as Plavix, usually for about 3 months.
All right. I thought we had one more question. Didn't we have one more question on there? It may have been the blood thinner question, too. Another blood thinner question.
And again, all right. And again, for that viewer, Jamie, just to clarify, that's for the aortic valves. For the mitral valves, we do anticoagulate patients with more powerful blood thinners like Coumadin, and usually that's for a minimum of 6 months.
All right. Very good. And if there's somebody watching right now that wants to be a patient, what should they do? What would be your best advice for them?
Well, the easiest thing to do if it's mitral or tricuspid is to simply call the structural clinic that's run on Thursdays and Friday afternoons, and that number is 410-554-6550, 554-6550, and you'll get a joint visit with myself, Dr. Wong, and probably one of the heart failure cardiologists, depending on what your symptoms are.
All right, very good.
And I would add to that if somebody's having any of those symptoms, the ones that Dr. Wang also alluded to, so, fatigue, tiredness, swelling in the legs, dizzy, lightheaded, all these things are important symptoms for which a person should be checked out. So they should call their healthcare provider and let them know about the symptoms to start an evaluation from there.
All right, they're still coming in, doctors. They love you. Kristen wants to know, how long can an individual live after quadruple heart surgery? Dr. Bethea, how long?
It depends on how many arterial grafts that you had and what your ejection fraction was going in, that they're able to revascularize all your territories. But usually if you got 4 vessels, then that almost always takes the heart off the table. And the average age for a male in the United States is 76, and for females it's 78.
All right, Dr. Bethea, thank you. All right, that'll do it for us, but keep the questions coming. We will make sure all your questions get answered. And this webcast is being recorded. You can find it after the broadcast right here on Facebook and MedStar Health, the YouTube channel. Thank you to the great panel that we have assembled here tonight. Thank you for sharing this. And thank you, the viewer at home, and have a good night.